My name is Ottestad. I'm one of the Anesthesia Pain Physicians at Stanford University Hospital and Clinics, and where I also did my training, residency, and fellowship, finishing in 2008. Since then, I have been the director of the acute pain service for about 8 or 9 years now, and also currently I'm a clinical associate professor there, as well as president of the World Academy of Pain Medicine Ultrasonography. Over the year 2017, I performed about maybe 25, 30 StimRouter implants, essentially covering the body, not quite head to toe, haven't done anything above the clavicles yet, but certainly upper extremity, shoulder, trunk, and lower extremity. At Stanford at this point in time, we have implanted probably 10 to 12 different nerves. I think some of the most common indications have been pain to the bottom of the feet with implantation of tibial nerve stimulators, as well as neuralgia paresthetica with implant of lateral femoral cutaneous stimulators. Also multiple suprascapular nerves, ilioinguinal and genitofemoral nerves, and in the lower extremity, saphenous, sural, including both medial and lateral sural cutaneous, perineal, and as I mentioned, the tibial nerve as well. At this point in my practice, the clear best indication for peripheral nerve stimulation, in this case StimRouter, is anyone with a mononeuropathy. The vast majority of these patients are patients who've been exposed to surgery or trauma, where there was some discrete injury to one specific nerve. If we can then figure out exactly where that nerve injury is located, then we have a fantastic target for nerve stimulation. What I've learned is StimRouter has really been helpful for every neural target I've tried. That includes small cutaneous sensory nerves, and that includes larger motor nerves. One of the initial questions I had with the device is, am I able to capture paresthesia and analgesia without activating the motor function of any of these peripheral nerves? And that certainly seems to have been the case with the first 25 or 30 implants. A second point is I've learned that in general the final lead works better when I see them back after 2 weeks of healing than it does in the operating room. So I've made some minor changes to my technique in order to speed the time in the operating room, because I can now trust that the lead will actually work when that patient returns, and I don't have to spend too much time trying to fine-tune it. In terms of outcomes, we do have a very extensive questionnaire we use at Stanford called Quire, which takes into account all the various domains of their patient experience, including mental and physical. At this point, we are still gathering data for that, but at some point in the future, we do hope to analyze it, look at patient outcomes across all these various domains. For now, we are really doing the more basic things, such as looking at the patient's activity level and pain scores. I would say my personal experience is patients have anywhere between 50 and 100% pain relief. I tend to have reasonably challenging patients in that it's not always a single pain complaint. Often they have multiple pain complaints, so when that happens, it's hard to get everything down to zero. But certainly for people who have more isolated pain that is fully treated by the StimRouter, I think those people tend to approach 75 to 100% pain relief, whereas the folks who have more diffuse pain come closer to maybe the 50% mark. But any patient I've had where the implant reached the correct target and stayed on that correct target has been extremely happy with their own outcome. And most impressively is doing the implant for a patient with foot pain. And when I see them for their first follow-up after device activation, for example, they'll bring me cookies and tell me that they managed to stand and bake for 4 hours. So as far as I'm concerned, that's a great functional outcome for that patient that they actually approved me with explanations of their physical status. One of my favorite patients is actually a police officer I treated over the summer of 2017. She unfortunately had a motorbike accident and suffered multiple wrist fractures and developed an extremely painful radial neuralgia. As you can imagine, it's challenging to ride a motorcycle with nerve pain in your hand, but more importantly, it's extremely challenging and likely unsafe to carry and use a weapon, a handgun, with that type of arm injury. Also, one thing that's very pertinent for this particular patient is the fact that we can't really use any sort of medication management that would influence cognition. In her case, I distinctly remember doing the actual radial nerve implant with her. She was completely wide awake. IV was only used to give some antibiotics, and local anesthesia was sufficient to place that electrode. And since then, she has more or less regained her full use of the hand and returned to the workforce as one of our local police officers. So definitely a success story with her. Peripheral nerve pain has been a very challenging diagnosis, I think, for us to treat over the course of decades. The pain can be very resistant to any kind of injection or intervention and medications. Even our best medicine is only going to help maybe 1 in 4 patients. Previously, as part of attempting to control this type of pain, we injected things such as steroids, botulinum toxin. We tried to do more risky and advanced procedures, including freezing the nerves, pulsing the nerves, or ablating the nerves. However, all of those treatments tend to carry the risk of new injury, new neuritis, sometimes worsening the pain, specifically with the ablation procedures. And you also lose function in the nerve. If you're attempting to ablate a nerve, that patient will have areas of skin that are numb. And clearly, if it's a nerve with motor function, they'll have functional deficits as well. Since these procedures didn't necessarily work that great, and even when they did work, they would frequently have to be repeated 1 or 2 times a year, the peripheral nerve stimulator implant has been a very interesting upgrade in terms of what I have available to treat these patients. With peripheral nerve stimulation, I can avoid doing any of the nerve ablations, which always carry that additional risk of worsening that patient's pain. But more importantly, it's a procedure I only have to do once. I don't have to see these patients back for more injections every 2 or 3 months, in which case every individual procedure I do, even if it works, we're aggregating risk over time. So StimRouter, as a result, I've moved above ablations in my own personal algorithm. A second reason to consider StimRouter earlier is that if you ablate a nerve and you're actually successful, it's going to be really challenging to actually stimulate that nerve with a StimRouter until it heals or regenerates.